So greetings everyone once again, and welcome to the 100th session of the online Optom Learning Series, OOLS. And today we have a very esteemed speaker, Professor Bruce Moore. Professor Bruce has been with us for, I think, since the starting of the series. He has taken almost 5 sessions for us, very kind enough to share his experience. But for those who don't know Professor Bruce Moore, he is an emeritus faculty member. After serving on the faculty for about 20 years, he was appointed the Marcus Professor of Pediatric Studies as he joined the faculty of the New England College of Optometry in 1997, otherwise also known as NECO. He has been involved in a majority of pediatric screening programs, and the whole life of optometry of Professor Bruce Moore revolves around kids and children's vision, and he has about 40 odd years of experience in that field, awarded many awards for the field which he specializes in, worked with many international organizations as well, helped to develop pediatric programs not only in the US but a lot of countries. And not to forget, he's also authored a few textbooks, and one of the textbook is kind of a basic which every optometry school library has as a reference book for pediatric optometry. So today, Professor Bruce Moore is going to talk to us about a very interesting kind of a topic where he wants us to know how children's vision can be used as a public policy in terms of the interaction, and he'll guide us through some ways, sharing his experiences and his thoughts on how we optometrists can play a vital role in children's vision. So welcome again, Prof, onto our platform. Thank you so very much, to take the 100th session. I think we wrote to you and we got a reply, I think within a couple of hours, despite, the time differences, and you were very kind enough to take up the session for us. So welcome once again, Prof, and let me just leave the screen time to you.
Great. Well, thank you very much, Fakrudin, for those very kind comments. And it's really a pleasure to be back again speaking in front of this really wonderful audience. So first, I want to just acknowledge my current and previous financial support. I've been funded by the National Institutes of Health, National Eye Institute, in an ongoing study, the Vision in Preschool, a study that has actually been going on since 1994. It's hard to believe. It's over 25 years now, and we've just applied for another 5 years of funding from the National Eye Institute. I also do some consulting work for Welsh Allen on the Spot Vision Screener, and I'm a faculty member at NECO, now Emeritus status, partly retired, and I'm also a member of the United States National Center for Children's Vision and Eye Health, which was established by the US federal government to help develop a universal and comprehensive system of vision care for children across the United States. And we've been working on that for about 12 years now. It's been very successful, establishing policies. So the talk today is really very different than the vast majority of the other 100 talks that have been given in this lecture series. This is not a clinical topic. This is more directed at public health and how I view how an increased focus on children's vision can be a mechanism of moving the profession of optometry forward anywhere around the world, but in this case, particularly in Asia. I want to acknowledge that what I'm going to talk about is based on my 45 years of experience in the US. So you might reasonably ask, how could someone who is a United States-based optometrist working in a different situation, different professional environment, different culture, how could I be providing a sense of what I think people in throughout Asia might do within our profession? And the answer to that is that I've spent a lot of my time, especially in the last 20 years, traveling around the world and working with programs and early development of optometry programs, educational programs, and professional organizations throughout the world, more recently, more so in Asia. And what I find is that what I'm going to talk about is actually quite universal. A lot of what I'm saying has been our experience in the US, but it turns out it is totally applicable to every one of the countries that I have spent time in. So I think that these are, again, experiences, but I think it may be useful for all of you to be thinking about how you can continue to move our profession forward. So let me start off by sort of giving an overview of the vision care system throughout Asia. And again, this is stuff you're all obviously intimate with, very aware of. Most of the countries that we're talking about have large populations and relatively few providers of eye care. There is, in general, very limited access to care for many parts of the populations of your countries. There is a medical, geographic, and ethnic, a socioeconomic isolation of populations. So the bottom line is that ophthalmologists tend to be concentrated in the cities, the major cities where they train. Wherever you train, you tend to stay. Now, that's true for optometry. It's true for ophthalmology. It's true for virtually every single profession. People move in from areas around the country. They train in the major city, the capital city perhaps, and they tend to stay there. So what does that mean for people living outside those areas? And the answer is not so much. Care is limited. Now, I view the potential role of optometry in the global view of eye care as providing the bulk of primary eye care. And that is certainly what's happened in the United States. Ophthalmologists in the last 20 years in the US no longer trained to be, the phrase was used, comprehensive ophthalmology, primary care ophthalmology. Not a single one of the residency training programs in the United States do that anymore. Every single ophthalmologist that has completed training in the last 20 or so years trains in a specific area of ophthalmology. And that means that more and more the primary care, the provision of routine examinations, provision of glasses, detection of eye disease, treatment of basic eye disease conditions, and then a referral to more sophisticated sources of care occurs through optometry. In the United States, there are about 40,000 optometrists. There are about 10,000 ophthalmologists. The vast majority of those ophthalmologists are in subspecialties. The vast majority of optometrists are in primary care. However, more and more over the last 20 years within optometry, that now is beginning to specialize as well. And I've been a pediatric optometrist for my entire career, and that's not all that unusual anymore. If primary care is provided by optometry, it will then allow ophthalmology to assume a higher and more appropriate professional role within their greater skill level. In other words, if you train as a retina person, you're going to do retina all day long if there are enough people feeding into that system that have retinal problems. Optometry is in a position to be more widely disseminated throughout a country. Again, in the United States, ophthalmologists tend to be concentrated in those places where they trained. So the major cities in the US are the places where the bulk of ophthalmology exists. Optometry is much more widely distributed, and I believe that that will be true throughout Asia as well. Optometry services are less expensive for patients than ophthalmology services in general. Therefore, it's more affordable, more people can access it. And the bottom line is that optometry can and should be, in my view, the primary care base for vision care. Now, here's a picture, and everybody kind of knows what this is. These are the pyramids in Egypt. And if you think about the three pyramids in the background, they're much bigger and much taller. You think about the three in the front, they're much smaller. The base of those pyramids varies. So the higher the pyramid, the bigger the base. And you could think of that as really being part of a healthcare system with primary, secondary, and tertiary care levels in any area of medicine and healthcare. In vision care, the primary care base should be optometry. If there is a wider base, if there are more optometrists providing more access to care, that means more patients feed into the system. More individuals are identified with conditions that require more specialized care. For things like cataracts and glaucoma, we would think of that as secondary care. Ophthalmologists can provide that in the United States. To a degree, optometry provides glaucoma, basic glaucoma care, care for anterior segment infectious disease, and ophthalmologists provide more complex care. So the more primary care, the more secondary care, and the more tertiary care. So in a sense, this is what is thinking about growing the market. A company like Microsoft or Google or Amazon or any of the other companies, big companies around the world, all want to serve and provide services and product to as many people as possible. They want the biggest market possible. In healthcare, it hasn't always worked out that way. It's the way it ought to be, but it isn't always the way that it is. Ophthalmology has always viewed optometry as a threat and has tried keeping it down. And that is particularly true in Asia that I've witnessed myself. So what's the current status of optometry in Asia? And again, you all know this far better than I do. From my view as an outsider, I would suggest that optometry is young and evolving more than anything else. It's a profession that is beginning now in some countries, been around longer in others, still has a long way to go. You're still developing who you are and what you do. Optometry is oldest in Asia in the Philippines. I understand that actually it originated over 100 years ago, although there was really only a very small number of individuals involved in it for a long period of time that were sort of the fathers of the profession in the Philippines. In many of the other Asian countries, optometry is far more recent, post-World War II, and in some cases, really only the last 20 years or so. The leadership within the profession in Asia is developing. There is a cadre of older optometrists, people more my age, that have been involved in the development of the profession for a while. And now the leadership is moving in the direction of younger people with different levels of education, different expectations, different experiences. And that's how things move forward. You have a problem with training and standards are still evolving. So the level of training in most of Asia is still, shall we say, in development. For the most part, you have 4 years of training after high school. In the United States, as you probably know, optometrists are admitted into optometry schools, 25 or so optometry schools in the United States, only after getting a bachelor's degree, university degree, typically from a high quality university. And now almost 20%, 25% of optometry students entering into the profession have master's degrees. So these people already have a very strong science foundation. In your countries, that science foundation is provided in the first or sometimes into the second year of training, which leaves a shorter period of time for optometric training and certainly a shorter period of time for specialized training. Throughout most of Asia, the scope of practice is limited. I'm not aware of countries where therapeutics are available. Maybe there are some, I'm not aware of that. Diagnostics are available under some circumstances. I suspect for those of you working in hospital settings or academic settings, you do have access to diagnostic drugs, perhaps in some situations therapeutic drugs, but by and large, it is a profession for the most part that relates more to eyeglasses than comprehensive eye examinations and treatment of a broad range of vision problems, including eye disease. So it is still evolving. You still have a way to go to reach the same level of education and clinical experience as in the United States. But you're rapidly moving in that direction, some countries faster than others. And in my travels, I've been very impressed where how, in particular, the younger cohort of optometrists is really pushing the profession forward rapidly and dramatically. Now, as to some of the problems, I think, in my view, from what I've seen myself, optometry is very insular and insecure. I would say that up until recently, that has been the situation in the United States. It's certainly still the situation in Europe, where the profession looks only at itself. It has difficulty seeing how it fits into the overall healthcare system. In particular, optometry around the world is under competition and threat from ophthalmology. And for better or worse, a lot of what optometry thinks about in its growth and development is how the profession compares to ophthalmology, how we conflict with ophthalmology, how we negotiate with ophthalmology for expansion of scope of practice. It really is ophthalmology based. We tend not to think of ourselves as being part of the broader healthcare system. Now, that was true in the United States, certainly when I came into the profession long ago. It is not true anymore. Optometry now is far more broadly integrated into the overall healthcare system, and that has turned out to be a critical improvement in our status and our ability to function and our scope of practice as well. The more involved and more integrated we are into the healthcare system, the greater our responsibility and scope of practice has become. Unfortunately, there's also very little collaboration beyond the vision care system. We do have relationships with ophthalmologists. We refer to them. We sometimes work under them, but we don't think about working with internal medicine or pediatrics or dentistry or mental health or any of these other areas in general. We tend to be very isolated. And then, of course, the overriding problem is that there are legislative and legal status problems in virtually every single country that I've been in. The scope of practice is limited. There are constantly fights going on with the ministries of health and ministries of education. And it has been a difficult struggle in many countries for optometry to get any recognition. And again, the scope of practice is often quite limited. Now, this is a very busy slide. And for the students out there, I want you to memorize all this, and this will actually be on the test next week. Just kidding. So the point of this slide is just to show there is a huge child population in Asia, not a big surprise. So the population of 4 of the countries in Asia are on the top part. India, obviously the biggest at 1.3 million. Philippines and Vietnam around 100 million. Malaysia, about a third of that. You look at the number of births, you have lots of births. Philippines actually, as of last year, has the highest birth rate throughout these Asian countries. But overall, on the bottom part of it, you can see that under the age of 15 years of age, roughly a quarter of the population of your countries are children. And I would argue that's a market. That's a huge market because people don't often think about serving that market. Think about refractive care. Yeah, you think about myopia in kids, but for the most part, you're thinking about people somewhat older. People don't necessarily think about routine eye examinations for younger people, but a quarter of the population of your countries are young. Compare that to the US, where about 18% is under the age of 15. And that actually is the highest percentage of any of the 30 most developed countries in the world. You look at Japan and Korea and most of the European countries, that percentage is closer to 10%. So you have about 2.5 times as many children per capita as Japan and most of the European countries, where birth rates have really shrunk over the years. And there really are relatively few children. Your countries, and you know this, you walk down the street, there are children everywhere. In Europe and Japan, not so. So a big, big potential market. You probably are all familiar with this, public health consequences of pediatric eye and vision disorders. So eye disorders affect about 10% of preschool-age children, 3 to 5 years of age. That number goes up dramatically today to about 50%, maybe more, largely as a result of the myopia epidemic that obviously we're all very aware of. So myopia happens, we know, at ages maybe as young as 5, more likely 6 or 7 years of age. From that point on, you've got a myopic population. So in school-age kids, you got a whole lot of myopia. You have a whole lot of vision problems that need correction. Many of these kids do not get detected and into treatment until a fair amount later. And children with hyperopia often don't get detected at all because they don't have any obvious problem that anybody can see. They're not squinting their eyes looking at the front of the room in the school. So they don't get detected. They don't get care. Now, to me, this next point is one of the single most important points of all when I think about the need for routine eye care for children. And that is that amblyopia is responsible for significant loss in more people younger than 45 years of age than all other causes of vision loss combined. So when people think about vision loss, they look at somebody my age and they say cataracts and glaucoma and retinal problems and diabetes and all the things we're all familiar with. That accounts for only a minute percentage of vision loss in people under the age of 45 years. Amblyopia is the most important cause. Amblyopia, in concept, is detectable in almost 100% of individuals at an age that should be treatable. Amblyopia, in concept, not in reality, but in concept, is treatable in the vast majority of individuals. And that's a nice way of saying that if you detect amblyopia and treat it effectively early enough, you make the most common cause of vision loss in more than half the population of your countries go away. You can make that go away. You can't make glaucoma go away. You can't make macular degeneration go away. You can make amblyopia go away. If somebody my age develops blindness, my life expectancy is relatively short here on out. Life expectancy of a child is obviously 60, 70, 80, 90 years more than mine. The effect upon that child, on that family, on that community is dramatic. Blindness in older people is obviously a consequence, but in terms of the economics behind it, it's much less of an issue. So there's an economic case to be made for detection and treatment of amblyopia. And that means there's an argument to be made for the examination and detection of vision problems in children at young ages, so you can make it go away and benefit the economics of your countries. Now, the epidemiology of vision problems around the world isn't all that different. Yeah, myopia is more common in Asian countries. We know that. Some of it is genetics, some of it is environment. But the bottom line is that the epidemiology of vision problems is really pretty similar pretty much everywhere. The effect of vision problems on learning is something that is wildly underappreciated by really everyone, and even, I would say, optometrists. The behavioral optometric or functional optometric pediatric community is aware of that, has dealt with that for a long time, but most optometrists in clinical practice don't pay a whole lot of attention to the educational effects that vision problems can cause. Now, it's pretty obvious why vision problems in kids are important. And, we know that vision loss, blindness, amblyopia at a young age is obvious. But beyond that, the relationship between vision problems of all kind and overall child health is underappreciated. We know that other than a refractive error, many vision problems are really a part of a systemic disorder in an individual. That's true in adults, it's true in children, it's frankly more true in children than it is in adults. So very often vision problems, again, other than refraction, is something that has a relationship to overall child health. A child with a vision problem may very well have other health problems going on. And primary care physicians that deal with children, pediatricians, often don't recognize that. Don't recognize that a young child with significant developmental problems may, in fact, have a vision problem. So the relationship to education we've touched on. There is absolutely a relationship between physical and motor development. Vision problems in young children are, in fact, a developmental problem. That means that other issues are often related. A child with a vision problem is far more likely to be a child with a hearing problem. It's far more likely to have fine and gross motor problems, on and on and on. Not to be ignored are the social and emotional developmental problems that a child may have as a consequence of vision problems. A very young child with significant vision loss may have difficulty bonding with the parents, with the mother in particular. So there can be really major consequences of vision problems that have to be identified early, have to be treated early. Otherwise, it can leave a permanent consequence to that child throughout life. Having said all of that, I would argue that this is not only a problem, but this is an opportunity. And I want to really emphasize that what I'm talking about is not just the downside of kids with vision problems, but there is an upside. There's an upside to our profession of optometry. Now, what are some of the specific problems throughout the world, but more so in Asia, related to pediatrics? Well, part of it is that there's only very, very limited specialized training programs and opportunities to develop additional skills and training in pediatrics. Yes, there are some programs in some countries. It's beginning. This is critically important. It's a first step. But by and large, the education that optometry students throughout Asia get is within those 4 years of training and really only within the 3 years or less of specific optometric training. So how much specific advanced training can occur in that relatively short period of time to the students? And the answer is not so much in many cases. Again, for those students who seek out more of an experience, they certainly are in a position to be able to get it in many cases, but in others, they're not. The other issue is that when people talk about pediatric optometry throughout Asia, in my experience, people are talking more about functional vision. They're talking more about developmental issues. They're talking more about what we in the US call behavioral or functional optometry. Vision therapy in particular at the center of it. And that is in no way a denigration, a knock on behavioral optometry. But what I would say about that is that in the US and in Europe, people who historically have been advocates of behavioral optometry tend to look primarily at an individual patient in their office. They tend not to think about broader public health perspectives about pediatrics. They tend to look at individuals and they don't tend to look at populations. I see that as a problem. I think it is critical that we need to be thinking about broad populations. And that really is what my whole discussion today is about. It's not about taking care of the one patient in your office. Obviously, that's important for you, the optometrist, and for the patient. But that is not going to by itself help in the expansion and development of our profession. In general, I think there is a very limited perception of the impact between vision and learning. Again, that cohort of behavioral or functional optometrist recognizes that. They've been talking about it now in the US for probably 50 or 75 or maybe 100 years, but people didn't listen to them. The idea that ophthalmologists would ever pay attention to this question of a relationship between vision and learning did not really come about until the last 10 or 20 years in the United States as a result of research, solid scientific research that showed that relationship. Prior to that, the anecdotal writings of behavioral and functional optometrists about this relationship was completely non-acknowledged by ophthalmology. And because they never really broadened that approach to large populations, it didn't really reach the level of the education community, except for individuals. But the broad educational community that worries about either preschool education or elementary or secondary education really did not think about the problem of a child that couldn't see. Yes, of course, a child with developing myopia who was squinting and having trouble seeing the blackboard would invariably be moved to the front of the room. But beyond that, beyond the myopia issue, the hyperopia issue, the amblyopia issue in particular, it was largely ignored. People never really thought much about it. And the other part of the problem, I have to say, that I do see really throughout Asia is that there really is a lack of awareness and adherence to evidence-based optometric care. Now, I talk a lot about the necessity of evidence-based medicine and evidence-based optometry because unless we use methods that have been validated in scientific research, we as a profession are on shaky ground. And that was unfortunately one of the problems that the behavioral and functional pediatric optometric community faced for a long period of time because they did not follow an evidence-based pathway. People simply in the scientific community, in the medical community, did not believe what they were being told. That's a problem. Now, there are reasons why it is still difficult throughout Asia to think about evidence-based optometry. And I know in my travels, even university professors in some of these countries have enormous difficulty accessing the medical libraries that are online. PubMed is the primary one in the United States. And I can sit here and I can access PubMed all day long without any difficulty at all. I know in my travels in many countries, I am unable to do so. There are governmental restrictions. There are other restrictions about cost. There's a whole variety of reasons why people can't access it. But because people can't access it, they don't access it. They don't think about it. They just basically continue to do whatever their teacher told them in their training. New ideas, new methods are hard to be disseminated. And that's a problem. So I've talked about some of the negatives, but I view all that as an opportunity. And I would say, on the other hand, one thing that I think is overwhelming in every single place I've ever been in the world, and I know this to be true, is that every single society in this planet has a special concern about the well-being of children. We care more about children than we do about anybody else. All societies want to do everything possible for children. I think, unfortunately, optometry has simply not recognized that as a reality. We know that as individuals, we know that within our families, we know that within our communities, but we haven't thought about that in relationship to our profession and the advancement of our profession. I think this is an enormous opportunity. So what are some of the pathways to change and growth? I think number one, and I know this is hard to swallow for many of you, we have to stop thinking about ophthalmology. We have to stop depending on ophthalmology. We have to develop our profession as a standalone profession and worry less about how ophthalmology sees us, how ophthalmology treats us, how we relate to ophthalmology. We've got to become independent of that. Yes, there's always going to be a relationship. Yes, we're always going to be collaborating. Yes, ultimately, if you think back to the pyramid that I showed before, we need to be part of the system of vision care alongside ophthalmology. But to advance our profession, we've got to go way beyond where we are right now. I will tell you that in the US, that has occurred in the last 20 years. And probably more than anything else, that has been why the profession of optometry in the US has advanced so dramatically in the last 20 or 30 years. We stopped worrying about what ophthalmology thought about us, and we started having confidence in who we are and what we do. Now, we need to continue to work with the traditional healthcare organizations, and particularly the traditional optometric international organizations and national organizations that exist. So, for example, the World Council of Optometry serves an incredible benefit to every single optometric organization in the world. They help to provide a whole lot of help and guidance and documentation as to what the profession is capable of. They definitely work with ministries of health and education and healthcare systems and educational systems around the world to develop the profession further. And that's absolutely essential. We need to continue to do that. The national optometric associations, the one for each one of your countries, are obviously critically important. And we need to continue to support those efforts and be part of those efforts. But frankly, we got to go a lot beyond that. And we need to do what I think of as a top-down versus bottom-up approach. We need to think in those terms. Top-down is my view of what those organizations I just mentioned are. World Council, the World Health Organization, International Association to Prevent Blindness. We got to work within those. Those organizations pay attention to what goes on in the country. They talk to people. They help to move things forward. But we've got to do something dramatic in a different way. We've got to have a bottoms-up approach. And what I mean by that is that as individuals, as optometrists, as optometrists within our communities, as groups of optometrists in our cities and communities across our nations, we need to push things forward. We need to develop relationships with other organizations. We need to develop relationships with ophthalmologists, with educators, with governments, with school systems, with healthcare professionals. We need to do those things ourselves in those communities that are separate from but related to the big organizations. So what that means is that we as a profession have got to engage both locally and nationally to further professional growth. I will tell you that a lot of what I've done in the United States in the last 20 years myself have been to be involved in those kinds of things. I'm a member of the National Center for Vision Care and Eye Health in the U.S. that was established by the federal government. And that is a group of optometrists and ophthalmologists, pediatric optometrists, pediatric ophthalmologists, primary healthcare people, public health people, government people, education people, a whole wide gamut of people working together who have come to recognize that vision plays a critical role in children's lives, children's future. We need to be thinking in terms of not just eyes, but furthering children. Because everybody cares so much about children, we need to work to further children's well-being. And that means we need to collaborate with other organizations outside the vision care world. We need to lobby alongside them for their issues. That way they will work with us on our issues. We need to stop waiting for change to happen by the top-down organizations, and we need to embrace efforts to make that change ourselves. We need to greatly improve the training and education for students and practitioners. And that means that the educational institutions in every one of these countries needs to continue to move forward and expand and strengthen, not only in pediatrics, obviously, but in every single area within optometry. We need to continue to push the development of advanced scope of practice. The way we do that is by improving the quality of education, improving the quality of clinical experience within that education, and specifically within pediatrics, we need to develop enhanced training programs. Now, when I came back to NECO 25 years ago, I started a residency program at NECO in pediatrics. We didn't have one at that point. There were a number of other pediatric residency programs at other optometry schools in the US, every one of which was more functionally oriented, more vision therapy oriented. The program that I established was, as I use the phrase, medical model. It looked at populations, it looked at relationships of disease to children, at overall healthcare to children. We established clinical programs with pediatric hospitals in the Boston area, and we were able to provide advanced training in these areas to a cohort of residents. Today, we have 2 residency slots at NECO. We train 2 pediatric residents per year. We're about to start our interview process for this next academic year. We had over 30 applicants for the 2 positions, which is typical. There are now many other medical model pediatric optometric residency programs across the United States. There are pediatric optometrists now in departments of pediatric ophthalmology at the 100 or so children's hospitals in the United States, now in the vast majority of those, expanding the base of the pyramid, as I talked about before, providing more primary care within those children's hospital pediatric ophthalmology specialty situations. That means more children coming through, more cases of amblyopia being identified and treated by the optometrist, more cases of eye disease being then funneled up to the pediatric ophthalmologist on staff and in training. More and more children are being served. There is a vast increase in access to care for children for specialized vision care needs across the United States that did not exist 20 years ago. Ultimately, that's what you guys need to do. You need to be providing more and more of that care. You need to be integrated more and more into situations where care is being rendered. And I know, based on the poll that was taken at the start of this talk, that many of you are involved in hospital settings and are already doing exactly those things. That's a beginning. That needs to continue. We need to, as I said, continue to spread out beyond our narrow interest in vision. We need to collaborate with all other kinds of issues. We need to think broadly about children. We need to work with organizations that care about children. We need to educate those individuals and organizations that go beyond vision about the role of vision in children's health and well-being. And that way we become part of the fundamental process of expanding services to children. And that is a way of convincing ministries of health and ministries of education of your countries about the critical value of optometry and how optometry can and should expand to provide an important role in that care. One of the big problems we have is that the population at large simply does not understand the value of vision care. And in this context, in particular, does not understand the relationship between vision and learning. Obviously, all parents want the best for their children, but they don't recognize that 15 to 20% of young children have a vision problem that can become an impediment to the learning process. Parents don't know that. In the United States, we have a system of providing special education for children that are falling behind the educational curves. There are similar systems in many of your countries, maybe as developed or maybe not as developed as in the US. About 20% of all children getting public education in the United States are involved in special education, as we call it. An argument to be made is that some percentage of those children getting special education because of difficulty in school are in that position solely because of a vision problem. They may have moderate to high levels of hyperopia or amblyopia or strabismus that might be impairing their ability to look at near objects, to be able to learn to be able to read efficiently and effectively. It impairs the learning process. If those children had been identified at a young age, those children may not have had those problems. If they didn't have those problems, they wouldn't be in special education. If they weren't in special education, there would not be the additional costs to the systems, to the school systems, to the taxpayers to provide that additional expense education to those kids. You can actually cut down on the cost of education by providing universal vision care. When I began advocating in the legislative areas in the United States, either in my state of Massachusetts or when I went to the US Congress, and we would lobby about issues related to children's vision. When I would go in 20 years ago and I would argue about how important it was to save children's eyes, that amblyopia and bad vision is a terrible problem and we need to do something about it. To be honest, nobody cared about that unless it was their child that had that kind of a problem. They were aware of it, or if they themselves had been in that situation when they were young. When we stopped talking only about that and started talking about how vision affects learning and how learning affects the taxpayers, then we suddenly got attention paid to us. That changed the equation. And as a result of changing that equation, as a result of changing our emphasis upon a much broader view of the impact of vision problems on learning and on child well-being, we have now been able to move forward much more effectively and aggressively in convincing the government of the states and the government of the United States to put additional resources into providing this kind of care. And that's happening. So, what do we need to do overall? Well, I would use one word, and that's collaboration. We have to stop being an isolated profession. We have to think about developing relationships much more broadly than within our own group, or sometimes within our own group of optometry and include ophthalmology. We've got to go way beyond that. We have to go and we have to become part of the vision care system, part of the healthcare system, part of the educational system of our communities and of our countries. We need to think about public health. We need to think about how philanthropic organizations that care about children's learning, care about children, understand our role in that. We need to work with government, most importantly, not just fighting for expansion. We need to do that, but we need to do that by convincing government that the role that we can play can benefit the population, can benefit the government, can benefit, frankly, individuals within the government. We need to recognize the linkages between vision and development and learning, and we need to convince other people about that. So the bottom line of what I'm saying here is that I believe that if we use the example of children to move our profession of optometry forward, we have a lot going for us. Everybody cares about children. Everybody is willing to put resources into improving the lives of children. This is a way that we can work with all these other groups, as well as ophthalmology, as well as government, as well as primary health care, to advance the goals of children, to advance our own goals of our profession, to make our profession stronger and more integrated into what goes on in our countries. And I think that this is potentially a very powerful approach. And I know that younger people in all these communities throughout your countries are thinking about some of these things. And I hope that this talk invigorates some discussion about how you can begin to work in that way, continue to work with the powerful organizations, the World Council of Optometry, but do things on a local level. So I'm going to stop now. Just want to say that this is, I think, an interesting poster that I came across. And this poster actually was published in the United States around the year 1930 during our Great Depression. And it was part of a program that Franklin Delano Roosevelt, the amazing president at that time, did to try to get people working again in the United States. And among all the other things that he did that helped to get the country over the Depression was hiring artists to do public works. This was a poster that was drawn that understood almost 100 years ago the connection between vision problems and learning problems. So this is not something that's new. This is something that's been around for a long time. And I think it's a message that we need to continue to think about and act on. So I'm going to stop there, and I look forward to having a discussion with you, answering some questions, and hopefully getting some stimulated discussions going. So again, thank you for the opportunity. And congratulations to this lecture series, which I think has been amazing. 100 lectures on clinical topics that are a great example of optometry doing things on its own to advance the profession, not waiting for somebody else to do something for the profession, but for people in the profession to take this disaster of a COVID problem and find good things that came out of it. So again, thank you. And I'll stop there.
Thank you. Thank you so much, Prof, for your kind words and, for sharing with us the important pathway. I would say this would definitely be really important for all of us to, direct ourselves in the pathway what you have guided us today. One important thing, I think, Prof, which you did mention that optometry has always been, waiting that ophthalmology would take it, work together, and, ophthalmology would give us a pathway. That is what we have been thinking always, that ophthalmologist will be doing that for us, or ophthalmology would be doing that for us. But I think you did cover a very important aspect that yes, they are there, but don't forget the other aspects of healthcare system, which may be very important for children's vision. So there's one question here. Do you think that screening vision and learning disabilities at regular intervals until the child is admitted to the school must be made compulsory? This is again a government policy kind of a question, but do you think that will help us to get more of the recognition of optometry field?
Yeah, actually, I do. One of the efforts that we've had in the United States that has been, frankly, an amazing collaborative effort has been to improve and provide an evidence basis to vision screening at appropriate ages. So there's now in the United States a universal recommendation that all children between 3 and 4 years of age should undergo a valid and scientifically based vision screening to identify important vision problems. Some other groups, the American Optometric Association, has advocated and argued that starting as early as 6 months of age, children should be seen and evaluated for vision problems. Whether 6 months of age is the right age, I don't know. It's probably too young. And to be honest, I think way too few ophthalmologists and optometrists have any interest, and in particular, any ability to do an adequate examination on a 6-month-old. But for 3-year-olds and 4-year-olds and 5-year-olds, I think methods can be developed that eye doctors, whether optometrists or ophthalmologists, don't actually need to be the ones doing the vision screening. And ideally, vision screening shouldn't be done by eye doctors. It ought to be done in the communities by teachers or by other groups that are trained to do an effective and evidence-based vision screening. So in doing that, we will identify up to 15 to 20% of 3 to 4 and 5-year-old children with significant vision problems that need either further evaluation or treatment, even at these very young ages. Immediately, that increases the number of children getting optometric care. An ophthalmologist isn't necessarily going to be the one to see those kids. It should be, I believe, an optometrist that is the recipient of the screening failure of a child that's identified in the screening. The critical element, though, is the screening's got to be done the right way. There's been an enormous amount of effort in the US, and frankly, I've been part of that with my vision and preschoolers study, where we helped to establish a strong scientific foundation for vision screening. But that's a critical element. I would also tell you that right now I'm part of a group that is developing a screening program for school-age children. In the United States, every one of the 50 states has requirements for doing vision screening of children in elementary and high school. That is a requirement throughout the United States. Unfortunately, a lot of what is being done in the schools, again, not by eye doctors, but by school nurses or teachers or other groups, is not evidence-based. And that means that a lot of what is being done is almost a waste of time. Things are pretty good at identifying myopia. Things are not good at identifying other vision problems. And we are beginning to develop a massive national study to devise a national approach to vision screening using both simple, low-cost, easily available techniques, along with using high technology at high cost to do vision screening. So we're looking at both approaches, and I am completely convinced that the techniques that we came up with for preschool age children in the US, which again were low tech, low cost, as well as high tech, high cost, are just as applicable in every single country on this planet as they are in the United States. Children are the same, the problems are the same, the techniques to identify those problems are frankly the same. We now know how to screen children's vision in the United States at a young age. We are about to embark on a systematic approach to figuring that out with older children. There is no question that setting up effective screening programs at the proper ages is going to identify vast numbers of children. Remember, I said about 25% of the entire populations of your countries are children. If 20% of that 25% has a vision problem, you're talking about millions and millions and millions of people needing eye care that are not getting it today. So the simplest, fastest approach to increasing the market for eye care for children is do good screening, identify kids, get them into the system. Some of those kids will have amblyopia. Fewer of those kids will have more complex problems that pediatric ophthalmologists and ophthalmologists in general can deal with. You expand the base of the pyramid, you expand the height of the pyramid, you increase the number of people getting care, you decrease the adverse effect on vision problems, having on learning problems in those children in your communities today.
That's right. So it is definitely going to be very useful. And I think that should be one of the good steps which can be taken forward. And just to connect that question, just to break this down, we did discuss about the therapeutic rights and prescribing drug rights in some of the countries. This question is particularly to the Indian context. But what do you think? How can we go about? Should we because of the drugs perspective, we can't do the drugs prescription. We can't use diagnostic drugs as well. Would you be giving us any tips on how can we go about that problem?
Yeah, obviously it's a big problem, but you could think of it once again as an opportunity. So there are ways of doing good refractions on children that will work most of the time, not all the time, to elicit moderate to high degrees of hyperopia doing non-cycloplegic refraction. And that is by doing a retinoscopy technique that enhances the fogging technique. So we all been taught the fogging technique of doing a subjective refraction. You put extra plus in front of the eye, you relax accommodation. If you do that in front of both eyes as you're doing retinoscopy, and what I do is I always use handheld lenses, and I talked about this in one of my talks some months ago. So I'll hold handheld lenses in front of the eyes like this. I'll do my retinoscopy like this. I'm fogging both eyes. I am providing blur on both eyes. I'm trying to relax accommodation to the maximum degree. That is a technique where in 90–95% of individuals, you will be able to determine moderate to high degrees of hyperopia. Your accuracy may be imperfect, but at least you'll be able to detect the presence of it. You then might be in a position to provide glasses that then over a period of time may help to relax more of the accommodation and over time increase the prescription. You can then over time and over lots of examples use the necessity for determining accurate examinations of children that can only be done with drops. You can use that as a way of trying to push the expansion of scope of practice to include the use of diagnostic drugs. That was part of what we did in the US 30, 40, 50 years ago, is we began getting that ability in some places using diagnostic drugs. That experience in one state was then used in another state to argue how important it was to be able to do cycloplegic refractions. And I think that that's a way of starting off in a few places where you can be successful, using that as an example and expanding it out, recognizing that the risk to the child of using diagnostic drugs approaches zero. There's virtually no risk to the child. People worry about this. You're going to have an adverse reaction. What's going to happen? I've been doing this 45 years. I've examined hundreds of thousands of children. The answer is no, it's not a problem. Just don't overuse the drug. So I think that you've got limitations. You can't use diagnostic drugs. Don't let that stop you. Find ways around that and then use the necessity of using diagnostic drugs in some percentage of children as a rationale for expanding scope of practice. So instead of looking at it as an impossibility, look at it as an opportunity.
That's right. And I think there are quite a lot of things we can do without the drugs. And as you said, look out for those techniques and then see. And if you really need to do that, you need to do you need to put the diagnostic drugs. I think your ophthalmology friends would be very happy to help that out. So again, collaborating would be one of the good points here, I guess. Right.
All right. So there's also go ahead. I was going to say there's a question here. But yeah, I was going to just answer this. So training of residency in the U.S. Well, so the 4-year optometric training program in the United States at the 23 optometry schools in the U.S. Is very detailed. It's very intensive. The first year, students get a basic science as it relates to vision education, along with some clinical courses, quite a few clinical courses actually, and some clinical experience. Now, because of COVID, it's been lessened, but we began sending our students out doing vision screening under supervision the first week of the first year of optometric training at NECO. That was one of the things that I instituted when I came in. We took our students out. We taught them to do optometric procedures, not only on themselves in the laboratory, but we took them out to schools and we had them work on young children. We had them do visual acuity testing and doing retinoscopy and doing stereo and other procedures, cover test pupils, EOMs, all of that on 3- and 4-year-old children the first and second week of their education. Now, did they know what they were doing at that point? No, but you learn by doing. You want to train a soldier, you don't have them in class. You train them to do what soldiers need to do. It's the same thing. In medicine, you don't train by sitting in a classroom necessarily. You train by doing. That's the only way you're going to learn. You got to learn by doing. So we begin clinical education early and intensively. And by the fourth year, it's all clinical education. The entire fourth year are 4 different clinical rotations, each 3 months long. One of which is a pediatric rotation. One is with elderly people at a veterans hospital, essentially learning glaucoma and macular degeneration. Others are in community settings, sometimes in specialty care settings, a whole variety of things. For those individuals wanting to do a residency in any one of a dozen different areas of optometry, low vision, contact lenses, ocular disease, pediatrics, take your pick. That's another year of training after graduation and after licensure as an optometrist. That is an intensive year where our residents are in hospital settings, they're in clinical settings, they're working alongside ophthalmologists in training and ophthalmologist supervision and optometric supervision in a variety of settings. They get an intensive education. They see probably more than 1,000 patients, pediatric patients, many complex, and they develop skill and training. And they also learn to do research, and they are required to present research projects and attend the Academy of Optometry meeting and present at the Academy of Optometry meeting their research findings. So we train them very intensively. And the expectation is that many of them will go on and become faculty either at optometry schools in pediatrics or be part of an academic department of pediatric ophthalmology at a children's hospital around the US. A handful go into private practice, but we've had about 40 residents graduate in our program since the beginning of the program. And almost all of them are either in optometry or ophthalmology academic settings. I was the first optometrist in the United States to get a faculty position at a medical school and to be on the faculty of a children's hospital in the United States. That was in the Harvard system. Now at that same hospital, Boston Children's Hospital, 9 of my former residents are now on the staff and have faculty appointments to the Harvard Medical School. So we have supplied individuals that have advanced training and are part of these medical systems. And again, expanding the base of the pyramid. Now you ask about the cost, and there's an old joke in the US, if you have to ask how much it is, you can't afford it. NECO per year is about $45,000 per year times 4. So optometry school is about $175,000 in cost, not including living expenses, which are in Boston easily $10,000 per year. So for the 4 years at NECO, you're talking about over $200,000 in cost. The resident actually no longer pays for the education, but actually gets paid. They get paid about $40,000, maybe $45,000. So in that last year of optometry school, they're paying $50,000. The next year, they're making $40,000 or $50,000. In 1 year, they get a raise of $90,000. It's one way to look at it. And then after that, they can go on and be employed. And typical salary of somebody graduating in a residency is probably $100,000, $120,000 a year in the US. So optometrists do well in the United States. It's a highly paid profession. And the educational cost, even though it's enormous, gets paid back pretty quickly. When I see my students at a meeting several years after graduation and ask them, are they still worrying about the cost of education, paying back their student loans? Everybody basically says the same thing, which is it's nowhere near the problem they thought it was going to be. They're doing fine. They're living a good life. They're happy with what they did. And they're very happy that they did the residency in pediatrics.
That's great. And I think the countries, what we are referring to, probably Asian contacts, we will definitely reach that one day. And I think we need to play an important role. Once, the government agencies recognize our work, I think that day is not too far. Right.
I think that will happen. Of course, the way you get the government agencies to recognize a profession is by doing good work, is by having a positive influence over children's lives or over your patients' lives. But I think, again, the whole point of this talk was particularly children, because everybody loves kids. If you can prove optometry does good for kids, you can convince the governments of the value of the profession.
That's right. Okay, this is a long question, but just to make things short, just that what I understand from this question is due to the pandemic, we know that children's kids are mostly on the online education, and we also recognize that more of online work will have more of eye problems. So, what do you think? Can we as optometrists take this particular aspect as an opportunity? And how can we use this as an opportunity to make it into something which is meaningful and let the profession be recognized?
Well, once again, this is a problem, but also once again, this is an opportunity.
Yes.
And the opportunity is that those government people are also doing Zoom calls all day long. They're staring at their iPhones or staring at a computer screen all day long. Yeah. They're having problems with their vision. So it's not that hard to convince them. If they're having problems with their vision, what do you think is happening to your own child? Your own child is having problems. This is contributing towards the difficulty that some children have. The inability of a child to stare at a computer screen for 8 hours a day with distance learning. This is a serious problem. Now, obviously, getting a child into an exam room during the epidemic is a problem. And, every country is struggling with all of this. In the US, optometry is a critical healthcare profession. So optometry practices are all open. They have been open almost from the beginning. There really was recognition of the importance of it. I would say probably less so for quote unquote routine exams, but obviously the complaints that people have about seeing a screen necessitate examination and treatment. So I think the situation we're all facing around the world of the epidemic, again, provides an opportunity. I think your national optometric organizations and as well as the World Council of Optometry have been talking about these things. And I think this is something that probably requires the top-down approach more than the bottom-up approach. But within your own communities, I think talking to people in the education world within your communities, do you have children that are not paying attention to the computer? Maybe those children need an eye exam now. Yeah. Maybe one of the reasons why those kids are not able to pay attention and why the parent and the teacher is concerned about that child is because they can't see, because they're hyperopic and they have eye strain. So you can use that as an argument.
That's right. Yeah. So that could be one of the way. And I think just if I may put it that way, recently in Malaysia, the Association of Malaysian Optometrists did a very fantastic job where, we had a lockdown 2.0, what we say here, and optometric services were not allowed to open in the beginning. But then the work from the Association of Malaysian Optometrists recognized the profession, and the optometric services were then allowed to open, and we were not recognized as just spectacle sellers. We were recognized as healthcare professions. So I think the associations are doing their part. It's I think our job. How can we look at a different approach? And at the end, we are going to meet at the same point anyway, and it's gonna be good for the profession. Yeah.
Well, I think that's wonderful that the Malaysian Association of Optometrists was able to do that. That's a perfect example of what I'm talking about. You had a problem, you viewed it as an opportunity, you convinced the government that our optometric services are an essential factor for patients. And now that's not going to be forgotten.
That's right. Yeah. It's in the books already, and I think quite a group of organizations, particularly the Optometry Council of India, does a lot of work in advocacy of the profession in India. So the whole point here is the associations. Again, I would say, as Prof also said, the association does their job, their part, but we as individuals also have a huge role to play to get the profession recognized. So that's where we come in as individuals rather than the associations, right?
I think so. I think that's exactly right. That's a great example.
Yeah. Okay, Prof. I think we have taken almost all questions with a good amount of discussion. Thank you so much once again, Prof. For giving us the time on a very early morning, Sunday morning, and I know it's snowy there at your place. It's quite cooling, and to do this during this soothing time is definitely, we are thankful for you, Prof. And I see a lot of thank you messages also on the chat as well. So thank you so much, Prof, for doing this.
Well, it sort of warms my heart to be able to share my experiences with all of you. This is, I think, what optometry needs to do. We need to share in lots of ways. We need to help each other, and we need to move the profession forward so that we serve our patients the way that we know we can. So thank you for this opportunity. And again, congratulations to all the efforts of all the people who are involved in these 100 talks. And I think it's just an amazing experience. And I congratulate all of you. Thank you.
Most welcome, Prof. Thank you so much for attending today's session. We will have continuous sessions planned. We do have planned sessions for the next weekend. Stay safe. Take care.